Hello and welcome to the HIV Cure podcast. My name is Sakhaba Susana Maruma, and yes, we are back bringing you more information on HIV cure and science. Today we are talking about children. So today we're going to talk more on HIV cure in children, and I have one of the best scientists, the guru when it comes to children and HIV. Hi, Dr. Gabby.
Hi, Sakhabo. Thank you so much for having me.
Thank you for joining us and coming to just empower us and enlighten us, because a lot of the times I think people don't even know that there is ongoing research on children, HIV cure in children. So yeah, kind of introduce yourself and let us in on what you do.
Okay, great. So my name's Gabriela Cromhout, and I'm a medical doctor, and I'm a researcher based at the University of KwaZulu-Natal in South Africa. And I am the clinical coordinator for the Ucwaningo Lwabantwana cohort, which is, it means learning from children in isiZulu. And so our study is based in KwaZulu-Natal in South Africa, and as you'll know, South Africa has the largest absolute number of people living with HIV, and KZN is one of the provinces that is most affected in this way. So there's a very high prevalence of HIV, so a high number of people living with HIV in KwaZulu-Natal. And so I run and take care of children and their moms on a cohort. So it's made up of over 325 mother-child pairs, where the children acquired HIV in utero. So this is before they were born. These children acquired HIV, and we follow these children from birth or as late as 21 days of life, which is very early still. We follow them from that time going forward. And our oldest children in the cohort are 10 years old this year. And it's really an incredible cohort to be part of, because we know these families and the neighbors, and we know everyone really, really well, because sometimes a neighbor will bring a child to come see us, sometimes granny, sometimes an aunt. So we know the whole family, and I have, the incredible honor of being part of these children's and these families' lives. And we get sent important things in their lives, like them graduating before they go into grade 1, and we get to see school reports. So, there's very much a personal side to this. But in terms of the research itself, we started this cohort, the team and the whole study was started in response to a case called a case of the Mississippi baby. And I'm going to go quickly through what that case entailed, so that I can kind of set the scene as to why we do what we do. So the Mississippi baby was a child who was born with HIV, based in Mississippi in the United States. And this child was started on treatment within 30 hours of life, and continued on this treatment and was in follow-up. And then the child stopped medication for a period and returned back into care, and had been off of therapy for a prolonged period. And this child, they couldn't find on the test, they couldn't find a detectable viral load, they couldn't find HIV in the samples. And they continued to monitor this child and kept the child off of antiretroviral therapy. And then at 27 months off of treatment, this child relapsed, so rebounded in that sense. And so the viral load shot up into the sky. And the interesting thing about this child in this case was the fact that this child was started on ART very, very early in life, and then had a period of on therapy, and then came off of therapy, and their immune system was somehow able to control the HIV so that it didn't replicate. Eventually, after the 27 months, it did replicate. But this gave hope and promise of the fact that children may potentially be better candidates for HIV cure than what adults are. And so this set the scene for why we started our study, the Ucwaningo Labantwana cohort, which is also known as the baby cure study. And so because there's such a high prevalence of HIV in KwaZulu-Natal, it was the natural choice of a place where potentially we'd be able to recreate the case of the Mississippi baby, where we start treatment within 21 days of life, so early ART. And the aim of the study was to see whether children could control HIV after this very early start of ART, and if they could potentially control it slightly later in life. So that was the basis for the study that I work on.
Oh, wow. That was a lot to take in, and also just you highlighting the work that you do and just the communities that you've built when it comes to just the baby care study, that it's much more than just a study. You've built, family, and just seeing them grow and in that different stages or walks of life. It's really amazing. And this really shows that when it comes to us working towards an HIV cure, it's much more than just us finding a cure, but also just looking into the people, how life is, a lifestyle and everything, being involved and just being part of that. And I just want to commend you on that. And you did mention a little bit about, the baby care study, how it started. So we would now like to know that what are some of the key differences on how adults and pediatric immune systems respond to HIV, and how does this influence cure research?
Okay, well, firstly, thank you. It's obviously such a privilege to be able to work with this incredible group of children and their families. So I feel like I'm the really lucky one to be able to be doing this work. And so in terms of how are children different, and I think you'll hear a lot of people who work with children or who are pediatricians, and they will say children are not little adults or small adults. Because you think, okay, a child is just a small version of an adult, right? But when it comes to the immune system and how children's bodies work, they, in some instances, work completely differently to the way that adults do. And so that gives us potential opportunities to harness these unique aspects of a childhood immune system that an adult immune system doesn't have, right? So the first thing is that in children who acquire HIV in utero, we are able to roughly estimate when they acquired HIV, and we're able to start ART as soon as this child is born. So very early treatment. And now what's really important about this is that if you can start treatment really early compared to when you acquire the virus, the viral reservoir is much smaller. And we can talk a little bit later about the viral reservoir, but one of the key things with these children is that you can start treatment early, therefore you have a small, less diverse reservoir, which makes these children good candidates for cure research. In addition to that, the childhood immune system, again, very different to an adult's immune system. So we know that children, if they are born with HIV and the disease follows its natural progression and there's no ART, over 50% of children die from HIV-related causes by age 2 of life. Okay. But if children are on ART, the immune system provides a really unique environment in which cure-related interventions can be used. So we call it a tolerogenic immune system. So basically it means that a childhood immune system tolerates and isn't very inflammatory or reactive to a lot of things, because remember, a child goes from being in utero to suddenly being born, and they come into contact with all sorts of viruses and bacteria and all the dangers of the outside world. So the child's, and specifically the infant's immune system, is primed in such a way that it improves a child's survival, right, past birth. However, HIV, if untreated, takes advantage of that, right? And that's why many children who aren't treated end up experiencing a lot of HIV-related illnesses, and it can lead to death by 2 years of age if you're not on therapy. But if you are on therapy, it sets the perfect stage for these cure interventions that are currently in the works. And so the beautiful combination of this very small viral reservoir in children and this less reactive immune system can come together, and that's why children are potentially have a greater chance of being able to cure HIV than what adults would.
Now that you've touched a bit on the immune system, the next question would be then, why do researchers believe that children may have a better chance, right, of achieving remission as compared to adults? And we talked a bit about remission on our past episodes, but you might just want to do a little recap for us so that we are with you.
Sure. So let me talk about children and their cure potential first. So you'll hear a lot of pediatricians and a lot of people who work with children in the medical field saying that children are not little adults. They may look like little adults, but in fact their bodies work in a different way to that of adults, and that's particularly true of the child's immune system. So there are certain things that are unique about children who acquire HIV when you compare them to adults. So first of all, we are able to estimate the time of HIV acquisition in a child who acquires HIV in utero. And we are able to start ART very early. So as you'll know, children receive vertical transmission prophylaxis, and that's their first experience of ART if the mothers are living with HIV and they give birth. And so these children are given ART immediately at birth. And what's so important about that is that when you acquire HIV, you have the laying down of what we call the latent reservoir. And I can talk a little bit later about the reservoir. But what's important here is that when you acquire HIV in utero and you start vertical transmission prophylaxis and ART, there is a much smaller reservoir that is laid down in children, and it's also less diverse than what you would see in that of an adult. So there's that. Then the fact that children have this unique immune environment is also an incredibly positive thing, we believe, in terms of prospect for HIV cure. So what do I mean by that? So the childhood immune system is less reactive and less inflammatory than that of an adult's immune system. So remember, a child goes from being inside the mother's womb to suddenly being born, and they are exposed to all sorts of viruses and bacteria and
exposed to the outside world, and this is the first time that they actually breathe air.
So their immune system is suddenly hit with all these new exposures, and their bodies are hit with all these new exposures, and their immune system is primed to allow them to survive that period, to allow them to survive that very drastic change from being in utero to living outside of their mother's body. And so HIV takes advantage of that less inflammatory, less reactive immune system when there's no ART. So you'll know from in the times when we didn't have ART available for children, and
greater than 50% of children by the age of 2 will demise due to HIV-related diseases, such as meningitis, tuberculosis, diarrheal diseases.
However, now we have access to amazing ART, and we're able to give it from birth going forward. And so this non-inflammatory, non-reactive immune system, this immune environment that is present in children, allows us to potentially be able to harness that as well as this much smaller reservoir in children, using cure-related strategies to be able to achieve cure in children. So that's what's unique about children. And then you asked me to speak a bit more about remission, and I think it's very important, particularly in children, to talk about to kind of define what we're speaking about. So it's sort of a large umbrella that has numerous terms under it. So we talk about eradicating cure or true cure, where basically you get rid of all the HIV in the body. And that's what we see in some of the adult cures, such as the Berlin patient and all the amazing 10 patients that have now been cured of HIV in adults. That's when there is no more HIV in the body. However, we also have something that we call remission. Now, that is when HIV is still in the body, but it's either deactivated or it's controlled so that it doesn't affect the immune system in the way that it usually would. So you can kind of think of the HIV as being deactivated or made dormant either by the immune system itself or something to do with the HIV itself. And so there are different forms of remission that people talk about, and a very common one is something I mentioned earlier, which is post-treatment control. And this is another name for that is ART-free remission. And basically what that means is that you have a period where you are on ART, and then you stop your ART and your body is able to control the HIV in the absence of ART. So post-treatment control. And that's very often what we refer to as remission when we're talking about children, and very often where cure strategies are aimed in children is this post-treatment control, particularly after the start of very early treatment. So we harness all the unique things about children to be able to work towards a cure that is achievable, and then we hope that parts of that cure will then be able to be used in adults as well. So I hope that answers your questions, just going back to remission and why children themselves are unique in terms of the journey towards cure.
earlier on you talked about some of the limitations that are there when it comes to, resource limited settings and low and middle income countries. So I want us to dive more into it and look into, some of the barriers that are there when it comes to early diagnosis of HIV in children, particularly in resource limited settings.
Yes, that's a great question. And I mean, we do live in difficult times in terms of the funding landscape of our HIV testing and treatment environments. So obviously the ideal case scenario is that women book their pregnancies early, so they go and they're tested and they find that they're pregnant, and they have all the relevant workup, which includes HIV testing. And if they are found to be living with HIV during their pregnancy, that they are started on therapy and that they are suppressed on therapy for as long as possible of that pregnancy. And then when children are born and they are HIV exposed, they are given vertical transmission prophylaxis and they are offered testing immediately at birth. And this is a way in which you can pick up HIV transmission, specifically in utero transmission. You can pick it up early and start treatment early. And because the idea is that the earlier you start, the smaller the reservoir, and therefore the less the exposure to the HIV there is for this particular child. But as you said, we are living in times where some of these things are uncertain. But I think the most important thing is that people ensure that they continue to test. So testing is very, very important. Making sure you're testing for HIV. If you are living with HIV, you are on therapy and you are adhering to that therapy. And then you ensure that children are diagnosed as early as is possible within your setting. And if that means that the testing occurs at birth, fantastic. If it occurs at 6 weeks old, you go according to your country's guidelines, but you make sure that you attend that clinic and you go for that testing so that you can ensure that if your child is living with HIV, that they can get on therapy as early on as possible. So I know that we are living in difficult times, but as much as we can control, we need to be controlling to make sure that
children are living their best possible lives when it comes to making sure they are diagnosed, they have access to treatment, and they are suppressed on treatment as best as we are able to do.
And to set them up for being good candidates for potential cures in future. And that's not to say that people who started treatment late will not be candidates for cure. That's not what I'm saying. But at this point, we believe that the best candidates for early cure interventions and the early testing of it will be these children who are diagnosed, started treatment early, and remain suppressed during that time before the intervention is given. Okay, so I think, the ideal case scenario is that any child who is exposed to HIV is tested at birth and is started on vertical transmission prophylaxis and is followed up beautifully. And in addition to that women who are pregnant and fall pregnant are tested at various stages of their pregnancy, and if HIV if they found to have HIV, that they are started on therapy immediately and that they are able to suppress their viral loads so that the chance of transmission is low. That is ideal case scenario. However, we do know that it's often very difficult in in lower middle income countries to be able to access care, and often women aren't able to come into care until they're pretty much in labor. And in terms of what the country is able to provide as well with their health systems and their economy, because we know at the moment there's also a big issue around funding. And so some of the systems that are in place might not necessarily have, for example, testing at birth. There might be testing at 6 weeks. And I think that the main thing here, what's so important, is that as an individual and within society, wherever you are, you access the treatment you are able to access, and you get the testing you are able to get, and the treatment you are able to get when you are able to access it. So I know I spoke about, children being diagnosed early and started on treatment early, and as being, the ideal candidates for cure. Remember that the majority of adults wait a long time before they actually realize that they have acquired HIV. And we are looking for cure in adults as well, right? So if your child is only diagnosed at 6 weeks and you are only able to access treatment at that point, that's completely fine. You do the best within what you are able to access, because even though we say, okay, these children will be what we think will be the best candidates at this point, this is just the early part of the research. Yes, we are making progress, right? And the idea is that in future, we will have a cure that is for everyone. It is accessible and affordable for any and everyone who has been living with HIV. To say is that, the best way that everyone can kind of get themselves to be their own version of the best candidate for cure somewhere in the future is you make sure that you get tested regularly, that if you do acquire HIV, that you start your treatment, and that you are adherent to it as best as you are possible, as best as it is possible for you to be, and that you maintain that adherence. Don't take those treatment holidays. Obviously, we know things happen in life, right? But, the very best adherence that you can have, remain suppressed, and make sure that everyone around you gets tested. That is the way that as a society, as communities, we can set ourselves up to be the best candidates for cure going forward. And something that was presented at CROI this year was that children who started on treatment a bit later were able to get themselves to a point, in terms of their results and the measures of their reservoirs, where the reservoir was absolutely tiny, almost immeasurable. So that's a really promising thing for the future. But you as an individual need to make sure that you are doing everything in your power to stay as healthy and in the best state to be able to access a future cure as possible.
Yes, and you just talked a little bit about, treatment initiation, that in adults, we do know that a lot of them, they've had HIV for a very long time and started treatment later, or even some, they know that they're HIV positive but choose to start treatment much later. Like even for the new guidelines, I think it was in 2016, the test and treat was initiated, and we had to now say that you test today, you start treatment as soon as possible. And now looking into children now, how does the delay in treatment initiation affect the long-term health outcomes for children living with HIV?
Okay, so it's difficult to say because obviously everyone is an individual. However, I'm going to go back to that stat that I quoted before, where, in young children, so if you are born with HIV and you don't have access to treatment or you don't get adequate treatment, the natural progression is towards a demise by 2 years old. So children will unfortunately generally die of HIV-related diseases like TB, pneumonia, and diarrheal diseases, and that are, linked to HIV if people are not able to access or are not adherent to treatment, because we are now at a point where, in theory, everyone should be able to access treatment. So I think the really important thing is, if you are able to start treatment early, you are able to maintain an immune system that is the same kind of strength and health that anyone else that you walk past on the street has. However, if you delay when you start your treatment, your immune system takes a hit from the virus, and that's very often kind of spoken about in terms of your CD4 count. And so your CD4 count drops, and body a bit to fight certain infections, and that means then that you are kind of more open to these opportunistic infections like TB and diarrheal illnesses and that kind of thing. So the same is obviously true for children, and more so in that first 2 years of life. So the important thing is ensuring children get on treatment and get tested as soon as is humanly possible.
Yeah, and we, earlier on you talked more on the Mississippi baby, and I just want you to just, how you explained how the Mississippi baby was groundbreaking when it comes to HIV cure in children. And I just want you to just share some of the lessons learned from the Mississippi baby just before we look into other notable cases that have happened or that happened because of the Mississippi baby.
Okay, so I mean, again, just for a recap, child was born with HIV, started therapy super early, and then went off of therapy for various sort of socioeconomic reasons, took their own treatment holiday, and then they were able to remain suppressed, and then eventually rebounded. So, I mean, I think from what's really, a big thing here is the fact that this child had whatever difficulties around her family life that ended up causing her to be off of therapy. And I think that, a lot of people who are living with HIV are living in areas where it's difficult to access treatment, where, socioeconomically things are difficult. You are potentially battling to put food on the table. And so I think it's really important to realize that, we can have all these beautiful systems that are in place, but if they're also not catering to everyone, and from, the poorest of the poor to the richest of the rich, that not everyone will be able to be well and to access things like cure. And I think it translates into a thing of cure as well, where we need to ensure that we are addressing areas of people's lives that are not just, HIV and research specific related. We need to talk about support and disclosure and the importance of adherence and, the socioeconomic support around all people in society allows for, when we're working towards an HIV cure, the fact that we can access it in a way in future that is equitable and, again, accessible to all. So that's just a non-science related thing that I think is really, really important that we also need to focus on. Because as we said, also within children, that time of adolescence comes with it its own challenges and burdens. And so that extra level of support, particularly from study teams, but also from from community-based organizations and religious organizations is really important. So emphasizing that within the greater community is really important. But when we go back to the Mississippi baby in terms of, a scientific basis, we see that obviously this child stopped this therapy. And again, I just want to, emphasize the fact that this is not something everyone should be doing. This is something that we as researchers and doctors can do in a very safe and structured manner in what we call an analytical treatment interruption study. So that's a very long name for basically saying we stop your ART under very strict monitoring. And this is usually done in these cure settings where we are testing some kind of intervention, and we, for example, in our ATI study, we bring children back once a week for the first month to ensure the safety of these children. And so it's really important that these sorts of things are not kind of tried by people like, oh, I feel like a treatment holiday. Again, we want to have everyone at their best potential place to be able to access cure interventions in future. So the Mississippi baby itself showed us that early treatment is very, very important in terms of making sure that the reservoir is small, and then also in terms of being able to set children up for potentially being able to be post-treatment controllers because of their unique immune environments.
Are there other notable cases in pediatric HIV remission, and how do they shape the current research directions when it comes to HIV cure in children?
Okay, so the very first one was that, that gained a lot of public interest was the Mississippi baby, which we've spoken about. And then there was the case of the French adolescent, the child in France, and a very similar case to another child that was known as the South African child. And these two children, again, one case, have been able to control HIV for over 10 years without any ART on board. And, they obviously ongoing research into these children who, are actually young adults now, and in terms of what made them different compared to their peers. And so all these cases were really critical in kind of understanding some of the underlying, questions that we have around cure. And then in terms of our study, we were able to, with these 5 boys, we were able to look and see, okay, what is similar and what is different with these children, and, why are they boys? And there's another really notable study, and it's that of Impact P1115, and they were able to find 4 children who were able to the very early treatment. So also building on the Mississippi baby case. However, we are still awaiting some of the data in terms of some of their underlying mechanisms. And there's some really exciting research actually happening in Botswana around the Tutelo Plus study, which I'm sure a couple of people who are listening may have heard of. And that's really exciting. Looking at the use of special antibodies in terms of potentially facilitating cure in these early treated children. So I just want to kind of go back and sort of speak a little bit more about the mechanisms that we were able to identify within our cohort. And so you might ask, okay, so these are right? So within our cohort, what was really interesting is that 2/3 of the cohort is actually female. So HIV was transmitted to more females than males overall within these areas that we were able to enroll in KZN. And in the cohort as a whole, we were able to identify these 5 boys, right? But we were also able to, having samples that date back to basically these children's births, we were able to look at similarities and differences. And so one of the things that I'd like to kind of talk about is around the immune system. And so in the immune system, females and males are different in terms of the way that the immune systems respond, okay? And so, for example, some people will have heard that females tend to have more autoimmune diseases, so things like lupus or Hashimoto's thyroiditis. And this is very strongly linked to something that we call type 1 interferon. So the type 1 interferon response. And basically, that's the part of the immune system where when your body is exposed to something foreign for the first time, your body releases this type 1 interferon to go and attack it. So it's your body's first point of call. So in the innate immune system, okay? And so females tend to have a much stronger type 1 interferon response than males overall. And this then means that women are potentially, have more autoimmune diseases, but it also means that they are able to facilitate, dealing with certain pathogens, bacteria, and that sort of thing faster and better than what a male's immune system is. And so that's one concept that I just want to highlight. Then the other concept is around viral replicative capacity. So it's kind of what we call viral fitness. So it's really how fast a virus can replicate itself. And so if I refer to it as viral replicative capacity, or if I talk about viral fitness, I'm talking about the same thing. It's how quickly it can churn out more of itself. And so we were able, in our cohort as a whole, to look at both the type 1 interferon sensitivity of these viruses, so whether they were able to be attacked by type 1 interferon or not, and then also the viral replicative capacity. So within our cohort at the point of the release of our Nature Medicine paper, there were 290 children at that point in our cohort. And so we were able to look across the whole cohort at the viruses that were transmitted to these children, and that we were able to look at the viral replicative capacity and the type 1 interferon sensitivity. Okay, so within the females in the cohort, we were able to see that the viruses that they acquired were type 1 interferon resistant. So all that beautiful type 1 interferon that females make was of no use because these viruses were resistant to it. Viral replicative capacity that was much lower, okay? So sure, these viruses were resistant, but they were a little bit slower in terms of their fitness. Then the males as a whole, in our cohort, the viruses that they acquired were type 1 interferon sensitive, right? But remember, males have a lower type 1 interferon response than females do, okay? But the viral replicative capacity was very high. So these were very, very fit viruses, okay? And then we had a look then at these 5 boys that were different and were able to control HIV themselves, just using their immune systems. And what we noticed, which was super interesting, was that the viruses that they acquired, so it's still the HIV, right? The HIV that they acquired was type 1 interferon sensitive, but then the viral replicative capacity of the virus was much lower than the other males in the cohort. So these HIV viruses, right, were sensitive to the type 1 interferon that these males were making, plus they weren't replicating as fast, which meant that these children's immune systems were able to contain the virus in a really, really beautiful way, that they didn't require any ART on board to be able to remain healthy, to have an undetectable viral load. And that's what's really exciting in terms of what we were able to find, because that's now how we hope to focus our work going forward on how to recreate similar situations in other children. So ensuring that the viruses that they are living with are potentially type 1 interferon sensitive with a lower viral replicative capacity, and so that then their immune systems are able to control their HIV as well. And so this is really exciting for the field as a whole, because it also has implications for adults, but how to use immune interventions in a way that can facilitate that same environment that then the immune system can control in the most beautiful way without any ART.
Yes, thank you, Gabby, for explaining to us how your study and research is working, and also giving examples. And, I love that you pronounce the fellow study so well. So I'm going to challenge myself. So
Mm-hmm.
I don't really know Zulu, but I grew up watching South African soapies, and I understand Zulu, like some parts I understand, but I can't speak it. So I want you to teach me how to pronounce your baby cure study. Yes.
Okay, so it's okay. I'm gonna say it first, and then we can maybe like break it down. Okay,
Yes.
so utwa, so it's utwa ningo lwabantwana, right? So utwa, it's a funny sort of click at the front of your mouth. You sort of put your tongue against your teeth and pull away for that C. So utwa.
Okay. Uta. Wait, yeah, Uta. Is that not the correct pronunciation?
Utwa.
Uta.
Yeah, that's good. Utwa ningo
Ukaningo
lwabantwana.
Lwabantwana. Uka. Okay.
Ningo? Yeah, you got it.
Okay, Ukaningo Lwabantwana.
There you go. You got it, girl.
Oh, yes, wait, let me try it again. Ukaningo Lwabantwana.
Yeah, boo.
Oh, yeah. So please give me land in South Africa. I'm coming.
You are welcome whenever.
Now when we're talking just research, and we need to be talking, ethics, and this is children now. So what are some of the ethical challenges that arise when conducting HIV cure research on children, and how can researchers address them?
Okay, so I think, as you rightly put, research in children is complicated because they're obviously a really special and protected population. And I think, communities are also very protective, rightly so, of their children. And so research in children overall comes with all sorts of issues and that need to be addressed. And I think specifically in the HIV realm, there are additional issues that we need to be very cognizant of. And so one of them is around the issue of disclosure of HIV status. And it's a complicated thing because parents don't know how necessarily to explain to their children that they are living with HIV. And however, when you're conducting research, children need to provide what we call assent. And so you will have heard of consent, which is, when you consent to being part of a study by yourself. But while different countries have different legal ages for that, very often the age of consent is 18. However, when we talk about research and, any interventions on children in general, children are required to give what we call assent. So that's not a full consent, but it's the child understanding at their level of maturity and understanding what is going to happen to them, or what intervention is going to be done on them, and that they have to undergo this intervention or whatever is being proposed. And the important thing about that is that the child needs to understand a certain level of what is going on with them at a baseline. And so that requires very often a certain level of disclosure. So in South Africa, we talk about assent in children from 7 years old. And very often parents will be like, well, how can I say to a child who's 7, you have HIV? So there's some really interesting work that we've done with the ATI consensus meeting that was done in Nairobi last year, where we really spoke around this. And so you can talk about partial disclosure. And so what exactly when I say partial disclosure of HIV status? So basically we talk about tailoring the level of disclosure to the child's maturity. So I'm just going to give some examples. We talk to our participants' families, and we say, we actually bring this up the very first day that they come and speak to us, right? When these children are 21 days old, we already plant the seed, okay? In terms of disclosure is something that needs to be an ongoing journey with children. You can't just disclose once and it's done. It's something that needs to be a journey with the child. And what we say is we suggest starting off and saying, because very often children will come to you and say, but why am I taking this medication? My friend is not taking this medication, and or my brother or sister isn't taking this medication. Why should I take it?
Yeah.
And so, using that as a springboard to starting the disclosure process and saying, no, your immune system requires some help from this medication to be able to stay healthy. And this medication makes sure that you stay healthy and you don't get sick. And that can be the first step in the disclosure process, right? You don't have to mention the name HIV at this point at all. But the child then understands, okay, it's really important that I take this medication so I don't get sick. And there's a reason that I specifically have to do it, because my immune system battles without it, right? And then as the child matures, you can start saying, well, there was a reason you were born. You were born with this disease that is the reason why your immune system's a little bit requiring of this medication. And so that can be sort of step 2. And then you can say it's actually, the disease is caused by a virus. And so that's the reason. And so you kind of build onto this narrative, and as the child matures and starts to understand developmentally. And then when you get to the point of naming what it is, the fact that it is HIV, it's not a shock to the child. And because they knew that they required the medication to stay healthy because their immune system couldn't do it by itself. And now they know that the reason is because of HIV. And so it's building on the understanding and the developmental level of these children. They have enough information to be able to also have autonomy of themselves when asked, are you okay for us to stop your medication, for example, in an ATI study, so an analytical treatment interruption. they will get a specific assent form. It will not, if they are partially disclosed, there's a special form that they will get where it does not mention the word HIV anywhere. An example of what might be in this informed assent document will say, you've been taking your medication really, really well, and we now are going to stop your therapy and monitor you to ensure that you remain healthy. But if at any point we see that you require medication again, we will restart it. Whereas an assent for a child who is fully disclosed, we would say, you have been virally suppressed on your ART for this amount of time, and your immune system is looking very healthy. If we stop this medication, we are going to monitor you very closely, and then if you rebound, then we will need to restart you. So that's some of the differences in terms of the assent and what's really important in children in terms of the disclosure process. And then so that's one of the ethical issues. And then another thing is around community understanding and ensuring that, you know, you have a community advisory board that really interacts with your specific community that your study is based in, so that, you know, the local understanding and cultural beliefs are brought in, and so that your documents and the way that you present the study to participants and their families is in a culturally sensitive manner, and also so that the community understands that this is not just, you know, experimenting on children willy-nilly, that this is a very highly ethically guarded group of children, and that there are, you know, data safety and monitoring boards as well as ethical review boards and these community advisory boards, in addition to the study teams who are looking after the well-being of these children. So that's just a very broad kind of idea of some of the ethical issues around conducting research in children.
Yes. So thank you for just explaining that and the whole concept of just consent and assent. Yes, and I want us now to look more into that now we know that, you know, they're still young and the parents are the ones that are consenting for them. So how can we ensure that parents, as well, you know, guardians in some cases, fully understand and consent for their children's participation in HIV cure trials?
Okay, so I think just to go back to part of what I was saying in terms of the community advisory boards and what a critical role they play as, you know, the link between studies and the community at large. And, you know, that also includes, you know, local advocates in communities. And so ensuring that communities as a whole understand the research that is ongoing, and so that, you know, if you are kind of approached to have your child as part of one of the studies, that you are at least peripherally aware that this sort of research is ongoing, right? So that's one thing that's incredibly important. And then I think also, I mean, we're in a really privileged position in the sense that we obviously know our cohort really well. And so we have walked life with them up in some of our kids up to 10 years old, right? Which is a massive privilege for us, but also is amazing in terms of, you know, the level of trust and communication that we have with these children as well as their families or caregivers. And so, you know, we're in a unique situation where from the moment that these children are enrolled, which is by day 21 of life, they are aware of what we are working towards in future in terms of these HIV cure trials, right? So we have great communication, and I think what's really important is ensuring that study staff are well trained, that they understand what is going on in terms of the studies and in terms of, the day-to-day practicality of that. And then also in terms of, how best to support the participants, and whether they be children or adults. And as a family, when going through explaining what exactly is going to happen in these cure trials, and then also ensuring, so a big thing is ensuring that they understand that they are completely within their rights to refuse to take part, to at any point, this is really stressful for me and my family, and we actually can't handle coming in every week. It takes too much of like an emotional toll on us to be stressing that our child might have had a viral rebound. And being able to say that, yes, I would like to withdraw now, and them understanding that, the study team is not ever going to hold anything like that against them, that they will still continue to receive wonderful care, and that the child will still be, protected and receive the medication that they need to receive, and that it won't be an issue of personally disappointing the study team. So that's something that I think is really important, ensuring that, parents and children are taking part, not because they feel that they have to or that they'll let someone out, but because they really want to be part of this and they understand it, right? And then a big issue around obviously understanding what is going to happen in the study is ensuring that people are, explained to in their home language. And I think that that's something that people very often overlook, because while a lot of people are wonderfully proficient in English or in whatever language, when you hear something in your own mother tongue, there is a level of understanding that happens that you can't get from another language. At least that's been my experience. And so making sure that your study information sheets and your informed consent and assent forms are easily accessible. And I mean that in terms of, the language. So whether it's, isiZulu, isiXhosa, whatever language this person, is their home language, making sure that they are able to read in their home language, if they are able to read. If they are not able to read, ensuring that you have someone who is able to go through the process, go through the document with them line by line, and ensure that they understand fully, right? And then when we're talking about children, ensuring that they're not just looking at this big page of writing, that is basically mumbo jumbo to them. It might be in their home language, but, I think all of us, you look at a page just full of writing and you're not exactly excited to read it. So really beautiful informed consent forms that have been developed within pediatric research, and specifically around HIV research, where they use like pictures and with like little arrows explaining what happens, and like a little blood tube, so that the children really can engage with the assent process really nicely, and to use simple language that's not filled with jargon, because I think, often researchers and doctors use jargon, and the everyday person doesn't understand a lot of that ridiculous jargon. And so making sure that it's in everyday language that is easy to understand and is accessible and not kind of just an information overload. And then I think what can also be really useful is in some of the studies that I've worked on, you also have a questionnaire after you've gone through the informed consent process with these families, where you ask them questions and they are able to answer to ensure that the level of understanding of exactly what's going to happen is there. And if there's still some confusion, you can repeat the process. So it's a very in-depth procedure that one goes through. And very often what we do with our participants is we explain to them just in a shortened version first the kind of underlying study that we're going to be doing, and then we ask them, is this something that you would be interested in being part of? And they're allowed to answer, and we then often say to them, okay, what we're going to do is we're going to send you home with the study information leaflet and the informed consent form. You can take this home, you read it at your pace, look over it, and then when you come back to your next appointment, we're going to go through it in depth with you, and then you can also ask us any questions. And I think that that's also really important, because you don't want to, none of us want to be in a situation where, let's give a ridiculous example, where someone says to you, okay, do you want to buy this car? And you're like, they're like, okay, you're going to buy this car. And you're like, I'm not so sure. Hang on, what, how fast does it drive? Oh no, it goes this speed. Okay, you get now. No one wants to be in that situation. You want to come in, see the car, understand how the car works, what the price is, all of that, right? And then go home and think about it. And so allowing people to fully engage with the process of, understanding what the study is about and understanding the implications for their everyday lives is really important, and not something that should be done in one session. So ensuring that it is an ongoing session, an ongoing process, and that your team as the researchers are always available to be able to answer questions. So our research counselors are absolutely incredible, and they often have WhatsApp conversations with our participants and parents, just if they're asking questions or phoning to just find out something about a dosage, and you're basically on call to a level kind of 24 hours a day, in very much a supportive way. And so I think that that's really important, particularly when it comes to children and young people who are taking part in HIV cure research.
All right. Thank you for such a thorough explanation, and also the highlighting the importance of language and simplifying the consent and explaining what the study really is, and even translating it to the local languages, which is something that I'm doing here, just making sure that, beyond the science, the community is able to understand what exactly is happening, understand the terms, and also be, comprehend enough what's happening to say that, okay, this is what this means. This is how we can be involved, and also now bring in even the language experts who are able to now to translate the science that they understand now to our local languages, like you mentioned, isiZulu, Setswana, and all these. So I commend you for that. And earlier on, you talked about access, that when it comes to long-acting injectables, we don't have access to that here in low and middle income countries, especially here in Africa. And now I want us to talk about access to HIV cure. What are some of the steps that can be taken to ensure that potential cures or long-term remission strategies are accessible to children in low-income countries when that happens?
Okay, so that is a great question. And obviously at this point we can only speak hypothetically.
Yeah.
So my answer will be general, but hopefully it will cover most of the points. So I think what's really important, to know is that when we speak about HIV itself, the majority of children specifically living with HIV are based on the African continent. So this is where, these interventions need to be accessed. And we know that it's often in areas that are harder to reach and don't necessarily have the most perfect access, transport or financially wise. And so it's a really, really important topic to be speaking about. And I think, you want interventions to be accessible just in a physical sense. Like I can get on a taxi and go and get my shot or my tablet or whatever it is, or a combination of the two, to be able to get my cure, right? But then also from a financial perspective, being able to afford that is imperative, because there's no point in having a cure that's available for people who are, high earners, where the majority of the people who are living with HIV are in lower middle income settings, specifically socioeconomically. So it needs to be equitable access, right? So then I think what's really important as well is, the acceptability of these cure interventions in future. And that all starts with, your community advisory boards, your community leaders, your advocates within your community. And I think that part, the education around HIV cure and, tailoring studies now to be acceptable within communities, for them to be able to access them in a way that's affordable and logistically possible, kind of sets the tone for in future when we do have access to these interventions. And so I think that, community members and community advisory boards, community advocates need to realize what incredible power they have at this point in time, to be able to set the scene for a future cure, because they are laying the groundwork for the coming cure. And I believe that it is coming, right? But we need to make sure that it's not something that's going to, happen and then sit up on a top shelf, a dusty old top shelf, because it's not something that's accepted by communities or not something that's affordable to the people who are actually experiencing and, living with HIV. So I think that's really, really important. And that requires, lobbying and presenting cases to policymakers and ensuring that the issue around HIV cure kind of remains front of mind for people, and so that it's not something that blends into the background and people who aren't in contact with it don't think about it. It needs to be something that people are constantly in contact with, and that, is the purview of the amazing advocates and community leaders. And so I think that they are critical in setting the scene for a cure going forward and making it accessible and equitable and culturally and appropriate and acceptable.
Wow, Gabby, this was such a jam-packed episode, doing so well, and also just gave, different examples, scenarios, and just explaining the practicality of what exactly is happening on the ground and the challenges that are there. And just to close it off, I want us to go back to the funding issue. That the 2024 funding landscapes are not the same as the 2025 funding landscapes. That now we've seen that now, as much as we had challenges in 2024 and before when it comes to just HIV cure research funding, but now it has gotten worse. Is a TikTok sound. It says that the pressure is getting worse. So I feel like yes, that's also what's happening currently right now in 2025. So then, how can policymakers and researchers now collaborate to the logistical as well as the financial challenges when it comes to pediatric HIV treatment and cure accessibility and the research holistically?
Okay, so I agree with what you said in terms of we are kind of living in a completely different funding landscape to what we were living in this time last year, which has been a shock to everyone in the HIV, in research in general, and specifically in HIV cure research. However, I think, it's very easy to kind of think about things in terms of doom and gloom. But I think it's also presents a wonderful opportunity in terms of, getting people who were previously working in their own little silos in being able to work together for the greater good in terms of access to medication, and lobbying for access. Specifically, we know that pediatric formulations are different to some of the adult formulations and often a little bit more difficult to come by. So ensuring that, this remains in the front of policymakers' eyes, whether that's through lobbying or, emailing or these community forums, we need to ensure that it remains front of mind. And then I think there needs to be a really big movement towards working together for the greater good of people living with HIV, and our colleagues' systems to be able to provide access to certain things. And I think it just requires a lot of creativity and goodwill. And I think, us as researchers and advocates need to make sure that we are talking about this at the tables and in the rooms where we have the privilege of sitting, and where there are people sitting who might have the potential to either contribute towards this particular area of, pediatric HIV cure research, or might know someone else who is connected in that way. And I think, initially the way that HIV and AIDS as a whole, the history of the disease has been sort of punctuated by incredible activism. And I think we are in a position now where we're having to engage that again. And there has been, amazing activism around it. And I think we need to keep that going. And I think it needs to, be part of our communities as well, where people are pushing for access to medication, to testing, and, to research funds as a whole, so that we can push this forward. Because, all these aspects, even if they are not necessarily impacting you as an individual, they impact society as a whole. So therefore you are affected. And I think that that's really important, that, it brings me back to the concept of Ubuntu, where, I am because you are. And I think we need to really harness that and embody that in a way that, we can uplift our society and ensure through activism and campaigning and really being creative in terms of everything that we're doing, in terms of pushing this agenda forward and helping with access to medications and to funding. So, yeah.
Oh, wow. What a powerful way to end the episode. And I hope that you listening, you were inspired, and also you got to learn a lot of what is currently happening when it comes to HIV cure. So what you can do as an advocate when it comes to, now we're talking, funding, landscapes, the changes that are there, and also the future of HIV cure research, and how you can come in. Thank you so much, Gabby, for your time and just, passionately explaining and teaching us, imparting us when it comes to HIV cure research in children, the baby cure studies.
Thank you for having me. It's been great.
Yes, and I'm going to say this one last time. Let's see if I get it right. So the baby cure of Africa is called Ukaningu Lavantana.
Yes, you got it, girl. Woohoo!
Next episode. Bye.